we'll give them some time. I'd like to welcome everybody here. It's World FND Week, and we're really excited. And we have with us today Dr. Kathrin LaFaver, Director of the Movement Disorder Clinic and Assistant Professor of Neurology at University of Louisville. And you've already been busy today. Can you tell us a little bit about what you're doing?
Yeah, no, thanks so much for having me. It's exciting because I've definitely seen this awareness week grow over the past couple of years, and lots of social media activity today. So it's just great to see. So yeah, we have hosted a patient lunch and a raffle. We'll actually keep the raffle going for this week. So
great. That's
yeah,
wonderful. As you said, it's really evolved, and it's always been an awareness day, even though we've had done a few activities. But last year we asked the members what they wanted, and they chose a week. So everyone felt like that we need a little bit more time. So we're really liking that everyone's getting so involved. One of the things that we've really tried to work towards is helping patients get involved with awareness and self-advocating and things of that nature. And you actually run the only program in America that is an inpatient program. Can you tell us a little bit about your treatment center?
sure, absolutely. So yeah, so to back off a little bit, as you are very well aware, there's just not a lot of treatment resources still available for patients with functional neurologic disorders. And I'm a movement specialist. So I was actually very fascinated from pretty early in my training by FMD. And I was rotating in the movement clinic at Mayo, where I did my residency in Minnesota, and saw a patient in a wheelchair, who couldn't move her legs after she was involved in a minor accident. And then came back 2 weeks later after she underwent their treatment program and was walking. And so at that time, I was a second-year resident and was just getting, learning about all the different movement disorders. And to me, I was just absolutely amazed and fascinated how someone could go from being in a wheelchair to walking over that short amount of time and, really have a chance at a new life again. And I really have been fascinated by FND ever since, and want to make my contribution towards helping patients. So I did more training, I was in fellowship, etc. And then I started my first position as an independent neurologist after fellowship. I came here to Louisville, Kentucky, and was sort of fortunate that the clinic here is very closely affiliated with the Rehab Institute. So in fact, we're housed in the rehab center, which is really great. And so I was pretty soon after starting here, approached the rehab director, Dr. Daryl Kalin, who's just a fantastic person and very collaborative, and suggested to him to start a specific program for functional neurologic diseases. And he was very open to the idea. And so that's sort of how we started out. And so we modeled our program along the Mayo program. And so at Mayo, they have patients spend a week at a hotel pretty much, and then come for 5 days in a row in an outpatient treatment setting and get mostly physical and occupational and speech therapy. And so I had seen many patients benefit from this program, but I also did feel that maybe adding a bit more support in the week, so specifically a psychologist who can really go through some of the challenges that many people have been facing. And, so we added that component, and then we decided to make it an inpatient program. A lot of it had to do with logistics and insurances, and it's a very complicated topic, as you know. And I know you had put me in touch recently with a couple people from FND Hope who helped working and hopefully doing some advocacy with insurance companies. But so it's a bit complicated, but we just felt it's actually um, sometimes easier to get sort of a very concentrated effort and benefit if you really have people here and give them a lot of expertise, but also some rest time during one week. And so we started our inpatient program, we call it MORE, for motor retraining, in 2014. And we have had now about 110 patients inpatient here. Yeah, you know, it was never started as a research study per se. It's a clinical program. We do try to follow patients to some extent and check in with them 6 months later to see how we're doing. But, you know, what's just been really amazing to me is, well, like you said, but we are the only program, and, you know, it shouldn't really be that way. FND is more common than multiple sclerosis, and in every bigger city are specialists for multiple sclerosis and treatment centers, you know, et cetera. And I'm hoping, you know, with my involvement with FND Hope and also training more physicians, and I'm really hoping that 10 years from now that the situation looks very different and people can access treatment wherever they live and don't need to travel around the, you know, across states, because that's really not an ideal situation by any means.
Definitely. I think just seeing how far we've come in the last couple of years, it is promising that that goal, you know, a 10-year goal is achievable to some, you know, to some extent, or at least within some larger areas. You mentioned that the psychologist is part of your team. I know a lot of times patients will say, you know, I was told I don't have any trauma that I found that this is related to. I've seen psychologists. How is it maybe still helpful for someone who maybe doesn't have that component? Would they still benefit from some psychological therapy?
Yes, I do believe so, but I know this is a very difficult topic, and many patients have made bad experiences with psychologists or psychiatrists, and I think it comes from this background that FND used to be called conversion disorder, or still is called conversion disorder, and there's sort of this concept of, oh, there's a trauma or stress factor that's really underlying why you have it, and if we just find that out and treat that, or talk about this trauma, find some other ways to process it, everything will be fine. I'm saying this sort of very simplified, but you know, I think it's really, there's ultimately no proof that this is really how the brain kind of works, and how do you connect these stress factors, which many people, many patients, depending on what study you read, have, to these physical symptoms that then kind of manifest. And there's many patients, and I would say in our practice around 40%, that we do not find any specific trauma or, you know, other stress factors than, you know, you can find in everyone's life, right? So everyone, gosh, if you ask for things like divorce or, you know, accidents or physical incidences that might have happened before, you know, everyone has these events, and they can sometimes serve as a trigger factor. But so, you know, the role of our psychologist is, so we have sort of, before people come to our program, they come to an intake clinic. So we run a multidisciplinary clinic for FMD once a month, and people see myself, they see a physical therapist and a psychologist. And first of all, we obviously want to make sure we actually agree with the diagnosis of FMD. So these are usually patients who have been diagnosed by someone and then refer to us for treatment. So we do a comprehensive history and exam, make sure that we agree with the diagnosis. And we've had a couple instances where we did not. So I think it is really important to be very open and you know, make sure we actually treat the correct diagnosis. And then the other purpose of this evaluation is for the physical therapist to really document the functional ability, the difficulties that might be present, and make sort of a preliminary treatment plan for the patient. And the psychologist also does an intake history, does sort of a life history, asking about prior issues with any psychologic diagnosis, things like that. But so interestingly, during the week program, what the psychologist will do, they'll actually look very similar for those patients who have or have not had prior psychiatric issues. So they follow a treatment manual that's been published by Alan Carson and others, which is called Overcoming Functional Neurologic Symptoms. And so we kind of boiled it down and supplemented it with a couple other things. But essentially, there are a lot of things to talk about. And I think, it's actually true for anyone who suffers from a chronic disease. And by the time that we see most patients, they've usually dealt with their symptoms for well over a year. And, just by that fact, there are a lot of things that can be talked about. And even if someone feels, well, I don't have depression, anxiety, things like that, there's often a traumatization by just getting this diagnosis. So many people feel like, gosh, we're not really understood or heard by the physicians, by other treatment providers. They might feel even guilty. They might feel sort of some guilt or some self-blame for having this. They might feel others accusing them of doing this to themselves or malingering. So there are a lot of things that can be very stressful. And then as people actually get better, there's also things to talk about, like, well, how can we make sure that you can maintain that success? What changes might be helpful in your life to continue guaranteeing success? And for a lot of people, it's sort of the, if you don't take care of yourself, you can't take care of anyone else. And we see this in lots of people, that they're often sort of a caregivers in the family. They take care of everyone else before it's time for them to take a breather. And so oftentimes the psychologist does a lot of coaching in terms of how can we move forward, cut down on some of the work you do, cut down on some other responsibilities to make sure you have enough time to put some of the principles into practice that they learn during the week.
Those are all really important issues to manage, because anytime you take a highly functioning, adult or even child that's involved in a lot of activities and all of a sudden take those away, it leaves definitely a void in your life. And so I think that that's an important aspect to remember. And also, as you touched on, the stigma that sometimes has been attached to the diagnosis, and sometimes patients have actually been abused by medical practitioners that did not know about the disorder. And so I think those are all really important keys. Can you tell us a little bit more about who else is on your team as well?
Sure. So, we have another movement physician who also sees patients, and a nurse practitioner. And we have a social worker, Diane, who is sort of a primary contact when we get referrals, kind of make sure we get all the records we need beforehand, and talks with the patient, talks about their insurance situation, et cetera. Because we want to make sure if people make the trip to Kentucky that it's not, unfortunately, if there's out-of-state Medicaid, for example, is not going to pay for treatment in a different state. So we want to make sure all these things, kind of practical things, are sort of in line before we accept patients. And then if they do come to the treatment weeks, a very important person is our admission coordinator, and she's just been fantastic in working with insurances, because unfortunately, oftentimes, the admission does get initially denied because there are a lot of patients have insurances that follow these Medicare guidelines, but essentially, you need to justify inpatient treatment based on medical necessity, and it's unfortunately more and more uncommon for people to come from a home setting to an inpatient rehab setting. That certainly used to be pretty common, for example, for people with Parkinson's disease. If they had a downhill development, to get people inpatient for intensive rehab. And in just kind of a current insurance climate, it's been a bit challenging. So we're currently looking certainly into more outpatient intensive treatment options as well as do others. So there's probably some more options available. But so while patients are here, the main parts of a treatment team are a physical therapist, an occupational therapist, a speech therapist who also attends to cognitive problems. So kind of speech and language are both sort of, expressing yourself. So these are both falling under the speech therapy realm, and the psychologist. And then we have Dr. Kalin, who's the director of our rehab center. He's sort of supervising the program, and they'll also see patients pretty much every day while they are here inpatient.
Great. We have a question from one of the panelists, and she's wondering, she says that a couple of her fingers want to stay bent the majority of the time, but she knows when she first wakes up that she's able to straighten them for a short period of time, but then they go back to this bent position. And I know you can't necessarily talk about her specific symptoms or anything, but do you see this quite common, this kind of change in symptoms throughout the day? And is that something that you can, or is that something that's usually touched upon at a treatment program like yours?
Yeah, so I mean, it sounds like a dystonia pattern, right? Of sort of bent fingers or locked in fingers. And for most functional movement disorders, it is actually quite common that symptoms do vary throughout the day. It's sort of one of the things that we typically use to actually make the diagnosis. So that story, kind of you wake up in the morning and things are pretty good and kind of get worse as the day progresses, can definitely happen. So I think both physical and occupational therapy can be very helpful in working with this symptom and trying to overcome it. And some of the strategies that are used can be, finding ways for the patient to, relearn more normal control over movements. That's sort of the whole principle behind this motor retraining. Because with FND, there's, all the tests you do are typically normal, right? So if you do an MRI of the brain or the spinal cord, you're not going to see any lesions, which means the nervous functions or nervous connections, the structure is intact. You kind of, and which is a good thing because that means you can actually retrain the brain to regain this control over finger control in this instance. And so the therapists can be pretty, need to kind of individualize the specific technique they're using to the patient. And oftentimes they try to engage them in different activities, for if the problem isn't with fingers or hands, some things can be working with some relaxation balls or trying to do a pegboard or things like that, while they engage the patient in a different activities. So sometimes you use distraction and relaxation techniques to maybe get some of that control back. And initially it's often completely involuntary, and someone might just notice, oh no, now my hand is clenched and now it's open, without being able to influence it. But if the treatment really works, we are able to get this control back under the patient's, will, which can be very, very, difficult to really explain what exactly happens, but it can be very successful and really nice to see that someone can relearn normal control. I would say generally we always tend to say, well, the longer the symptoms have been there, the more difficult they can be to treat. And if you kind of think about brain plasticity, maybe that makes sense, or kind of ingrained patterns. But that being said, we have had the average duration of our patients' symptoms is around 7 years. So, we have had many patients who've had even longer than 10 or 15 years of symptoms. And it's difficult to kind of put these success rates in numbers because, we have people do a self-rating at the beginning and end of the week. We also do like a video, and we can kind of do sort of a formalized video score. But then, as we just talked about, the symptoms can fluctuate throughout the day. So in a way, I think it's actually more meaningful to not be so much stuck on like, well, how many abnormal movements do we see, and more towards, well, how functional do we get people in their daily life? And often, so for the people who are local here in Louisville or kind of close to here, I do usually see them back at least every 6 months or so, and continue following them. And we've seen many, many patients who have maintained their treatment success for 3-4 years now. And so what they tell me is, there's rarely a patient who will say, oh my gosh, I'm completely cured from this, although we definitely had some in that category, and they usually, I do not continue following them. But even for those who do extremely well, they might still say, oh gosh, when I'm really stressed, I kind of feel whatever it is, my shoulder really clenching up or things like that. But I know now what to do, and I have learned some techniques that can really help to catch these things very early and control them. And I've been really amazed of how well this has worked for many people, that they just do like a week of treatment, and they learn sort of these self-regulation methods that can be helpful for years even.
So how often do you see relapses, or is that quite common as well? Or I guess, would you characterize it as going into remission? Because I can see if you've got some ongoing patients, how do you characterize that kind of ongoing?
Right. So so I would call someone in remission if they truly have not experienced any movement symptoms, for probably over a month or so. So we definitely see that. And we just had a couple of patients at the lunch today that we had, and there was someone who was previously given a diagnosis of multiple sclerosis that was then reversed to functional gait disorder, and he is able to be fully functional now, and went from having multiple falls a week to just being normal and walking around and traveling. And but even he was saying like, well, if I sit for a very long time, I'm struggling a bit. And so he has adapted to some extent. He tries to avoid sitting for a very long time and does his stretches. He still does some exercises every day. So I think it's sort of all, I think in general, what I've sort of learned over these past 4 or 5 years that I've been doing this treatment program now, I think in general, for many people, it is necessary to think of it as a chronic condition, one that needs to be managed and that can be very successfully managed. But I think in a way, it's like having hypertension, right? If you have high blood pressure, well, usually you just, it's not like, oh, well, you just fix your diet and it's all gone. I mean, it's, for many people, conditions like that or diabetes, it's something that they will need to think about every day, or take medications, or, watch their diet. And with FMD, I think it's more watching other things. And for many people, it is managing their stress levels, their relationships, doing more self-care things, and learning sort of these techniques to interrupt abnormal movements as they occur. So I don't have a great specific number because if someone just has, is very functional, is back to work, is able to engage with the kids, but maybe does have a little bit of twitches before she goes to sleep, well, would I call that a relapse? So it's difficult, but again, I'm encouraged by overall being able to get many people sort of back to their social lives, their family lives, and just much more functional compared to when they came in.
That's wonderful. We have a couple other questions. Now we have some that have raised their hand. We used to have people ask their questions that can get kind of difficult sometimes. So we do ask you just to put your question in the chat and we'll pull them from there. We do have another question regarding paralysis. And is that a different, I know you don't treat seizure activity at your clinic, correct?
Yeah, so, you know, there's certainly a lot of overlap between all manifestations of FND. So generally, because we are an inpatient program so heavily focused on PT and OT, if someone has seizure-like spells that, for example, only happen once a week, you know, it's difficult. And also, if you have spells where you truly can't really interact while you have the spell, it's also difficult for physical therapists to really work with a patient during that time. So I think generally for patients with seizure-like spells, working with psychology and cognitive behavioral therapy is sort of considered for standard of care. Although, again, we don't have tons of trials sort of backing this up, and probably other ways of moving forward can be helpful too. But yeah, so generally one of the criteria for our program is daily symptoms, severe enough symptoms where someone has trouble with their daily functioning, to sort of, again, to justify the intensive inpatient treatment, and also lack of spells where people would lose awareness, essentially.
So would someone who has temporary paralysis, would they still be a candidate for the treatment?
Yeah, we had, so I think weakness, yeah, I mean, again, I think these different categories are definitely somewhat artificial, but yes, we definitely had people with weakness, leg weakness most often, and yes, we had a patient, for example, who intermittently could not use both of his legs and lost his speech completely, and he was able to regain normal walk and function. So yeah, I think the techniques for weakness and movement disorders with too much movements, I mean, in a way, it's kind of the opposite. It's like too much or too little movement, but ultimately the strategies that can be successful for rehab are along the same lines. Yeah.
And someone asking about leg spasticity, that would also be a functional, or could be a functional disorder, is that correct?
Well, so true spasticity is really defined as, increased tone in muscles and increased reflexes, abnormal reflexes. So if true spasticity is detected by neurologists, it would generally not be considered a functional symptom and would certainly require more workup. But I mean, I hear the term used pretty loosely often, or people might refer to spasticity and just meaning that their muscles feel tense. So I guess I would be a little bit more careful with that term and determine if it is sort of fitting the spasticity that we would see in someone with stroke, for example, or spinal cord lesion, or if it would still be in the FMD realm. But yeah, I mean, lots of people do experience their muscles cramping, their muscles feeling sore, their muscles feeling, very tense. So that's a very common thing, along with often chronic pain that can kind of go along with that for sure, yeah.
Do you find that there's a tendency to, anytime there's a new symptom, to think that it is functional related? How do you kind of avoid that, or what tips would you give to a patient on how to differentiate between the two, or when to seek medical care?
Sure, yeah, I think that's a very important question, because of course, well, as with any other illness, you can have two different things, right? I mean, you can have well, anyway, you can have a lot of different illnesses at the same time, theoretically. So with FND, it certainly can be very tricky because, well, you guys have a very good brochure that kind of explains, well, FND can really present with many things, including headache. And I often actually do that when I see patients in clinic. I take, or actually it's either your brochure or the one from neurosymptoms.org that will really say, you know, FMD can cause headaches, blurry vision, weakness, tremor, and, you know, to kind of help people understand that a lot of times many of the symptoms we're experiencing are kind of explained by this one diagnosis, and that it's actually more helpful to have sort of a comprehensive approach and start working on some of the symptoms and not trying and sort of, again, the relaxation training, the working with the psychologist can be very helpful, and we try to kind of bring the brain stress level sort of generally down. What we often see when people are so, you know, in kind of the trenches of being subject to all these different symptoms, they also have this hypersensitivity. So oftentimes people really are hypersensitive to light and noises. And so it's sort of one explanation. You've got to find a way for the brain to be more calm and more relaxed, and then a lot of times many of the symptoms will get better even if we didn't specifically target them with the treatment, such as the vision symptoms, for example. But yeah, so of course, so say someone had a tremor that was diagnosed as a functional tremor, and all of a sudden wakes up with inability to move the legs. So I would say, well, if there's a completely new symptom, I would go ahead and try to get this evaluated. I mean, depending on the nature of the symptom, you know, to determining how urgently it should be evaluated. But certainly if there's complete inability to move the legs or things like that, I would certainly recommend to get this evaluated, because, you know, it doesn't, like the seizures, I mean, you can have epileptic and non-epileptic seizures at the same time. You know, having a functional neurologic disorder doesn't protect you from having a stroke, you know. However, if things have been ruled out and sort of same symptoms keep popping up, you know, keep getting better and popping up, but sort of follow the same pattern, or then, you know, maybe last for half an hour and then completely go away, and it's sort of been an established pattern, it is certainly not necessary or not recommended to go to the emergency room every time for a new evaluation, because that's going to be very unlikely to yield to a new diagnosis. But yeah, I would, you know, it's difficult to kind of give an umbrella recommendation. But I mean, you are correct. I mean, unfortunately, I really do think that a lot of work has to be done to educate providers in the emergency room, and you know, any general practitioners a bit better about functional symptoms, because of, as we talked about a little bit earlier, sort of that stigma is very real. And sometimes people do feel, well, once they have this diagnosis, that they're not taken serious and we're just kind of dismissed as, oh gosh, it's just anxiety sort of thing. Right. So yeah, again, I think that kind of comes from this misinformation or perception of some healthcare professionals that people are in some way responsible for their symptoms or have control over their symptoms or just seeking attention. And, you know, as we know, that could not be farther from the truth. I mean, usually patients are just very distressed and are looking for help, just like anyone would, experiencing some of these symptoms. But yeah, I think if there's not a perfect answer, I mean, I think you guys have a ER, like a toolkit to explain some of the diagnosis, you know, to ER physicians. Because there can be really some very real dangers associated. For example, people with non-epileptic seizures looking like they are in status epilepticus and getting intubated, which, you know, would not be necessary. So it's, again, I think we need more education.
I think that that's a really important part that you mentioned, is the education on both patients' part and medical professionals as well, which segues kind of into the final thing. We're running out of time, but I wanted to just mention you do a training program for the MORE program. Is that open to general practitioners, or who is that geared towards in your training program that you do?
Yeah, so we were looking for a way to sort of spread our expertise here now that we've some of the therapists have really gained in these past 4 or 5 years. So we did one treatment course in 2017, and we just did one actually last month. And we had quite some interest. So it was very encouraging to see. We actually had so physical, occupational therapists, psychologists come from 13 different states, and 2 even from Canada. And so I'm hoping, and they took the course here. It was sort of a full day course talking about all these issues and showing really real demonstration videos how our therapists were really working with people in practice. We also had a fantastic hour with past patients coming back and sharing their experiences of being in the program and how it has affected their life now later. So it was really, really good day. And so that is now available, still available for registration, and I'm happy to send you the link. We often hear this, or if we see patients here who are not local to here, and there might be some obstacles for them to, not everyone can come here and do our program, and personal reasons and insurance reasons or lots of other reasons, or just, living too far away. So we have now the opportunity to share that link and encourage them to tell their physical therapist to maybe look at that course and, gain more expertise. Because, Glenn Nielsen in the UK did a very, very nice study where he compared 5, like a similar setup to the Mayo program. It was just physical therapy for 5 days. And he compared the outcomes of patients who worked with him, essentially, or someone else who was really specialized in PT for functional disorders versus going to a PT, who was in the community and had no experience. And the difference was huge. So I think it was around 70 to 75% improvement with the specialized FMD treatment versus only 17% with a community physical therapist, which just goes to show that, well, not surprisingly, you sort of need to be trained for the condition you're treating. And what I often hear, because many of our patients who come here have had physical therapists before, but what they need to work on is the movement planning and the movement kind of the flow of a movement. It's sort of usually bigger kind of pattern generation, things like that. And for example, they don't need to work on strengthening muscles so much unless they've been, in a wheelchair and the muscles really have atrophied. But usually what I just hear is that the physical therapists, if they haven't treatment experience, or they don't really know what to do, and might just work on muscle strengthening, and someone who actually does not have weakness, it's really more an activation problem. So I think that is very important. And again, we are still working on actually getting, so it was a CME program, so people got continuing education credits if they came, and hopefully we can also do that for people who do it online only. But it's definitely, they can buy the program. It's not that expensive, so I'm happy to send you the link. And we often encourage patients to share that with their local providers to maybe gain more expertise.
And that's really the best way to get it into the hands of every physical therapist that's working with a patient, right? Is if the patient takes the information, then we've now educated everyone that they're working with. So if we can get, we've actually been tweeting that, but we will link it when we rebroadcast and put this on our YouTube channel. We'll make sure that we add the link to that program so patients or medical professionals can disseminate that out to whoever they think would work best. Is there anything that we haven't touched on that you would like to just add before we go?
Yeah, I mean, I would just say, it really shouldn't be this way, right? But the patient needs to educate their healthcare team. But I think, it has happened for other conditions, or it's also the case for people who suffer from a truly very rare genetic condition that they'll become the expert on their condition, and they'll probably know more about it than most of the doctors they'll ever talk with. And, so I think it is just an opportunity with all the education that FND Hope provides and, others provide, that the patient themselves really becomes educated about it and hopefully finds healthcare providers that are open to, learning and maybe changing their approach to this. And hopefully we can change many in the course. And there is this new society now, started by Mark Hallett and John Stone and Ellen Carson, and I really hope, and we do see this happening, that just in general in the field there's more interest to learn about it and to really help patients. I think overall I'm definitely encouraged.
That's fabulous. We really appreciate you joining us, and for those of us, the patients that are attending, we have webinars going on throughout the week. Tomorrow we'll be with Dr. David Perez, and he's going to share some of his studies that he's been doing with fMRIs. And then we'll have John Stone, Tim Nicholson further down the week. And so we thank you again for your time, Dr. LaFaver, and thank you for spreading awareness.
Wonderful. That's good to see you. And yeah, we'll be in touch.
Thank you. Have a great day.
Have a good week, everyone. Bye.